Okay, good evening, dear students. I'm Dr. Pavan Kulkarni, faculty for the subject of oral pathology. So today here I am to discuss the recent November paper oral pathology MCQs. So I'll try to solve. So we have already seen the subject thoroughly, and if I'm not wrong, almost 95% of the questions we have discussed already. Whatever the questions have come, 95% of the questions we have discussed. So it's almost same dot, same point to point, same images, same MCQs, same important points that we need to emphasize, all has been discussed. So let me start with the first question. The first question says that a 55-year-old patient presented with a pain and swelling on the palate. Histopathology showed cribriform pattern and Swiss cheese pattern. The probable diagnosis is, see, this image I have discussed. This image I have discussed multiple times. Swiss cheese pattern. So Swiss cheese pattern is a typical pattern. If you open the notes, this image is there. We have discussed already that Swiss cheese pattern is typical of the adenoid cystic carcinoma. It is very simple question that you need to just emphasize on Swiss cheese pattern or cribriform pattern. Okay, so canalicular adenoma, pleomorphic adenoma, mucoepiderm, all are salivary gland tumors, but Swiss cheese pattern or cribriform pattern is a characteristic histological feature of adenoid cystic carcinoma. Okay, so that's a very unique point about this. And one more point, see, this is a simile, how to compare. These are all cystic spaces. Okay, it looks like as if it's a Swiss cheese. This image we have already discussed. And one more point you need to remember about this is perineural invasion. So this adenoid cystic carcinoma is one more unique point about that is it shows perineural invasion. Because of perineural invasion only, the adenoid cystic carcinoma shows a rapid spread. It exhibits a very rapid spread. Okay, let us move on to the next question here. A patient presented with the swelling in anterior maxilla. Radiographic features showed unilocular radiolucency around the impacted tooth. Histopathology showed odontogenic epithelium in duct-like pattern and eosinophilic material within it. The probable diagnosis is. See, first of all, we have to rule out. In this, if you see, swelling in anterior maxilla. Point number 1. Number 2, unilocular radiolucency around impacted tooth. So usually it is the case of AOT. See, this is characteristic of AOT, and this we have already discussed that what are the swellings in the anterior maxilla. But only one point which is a bit confusing, the examiner has confused you here, is unilocular radiolucency. Because usually what happens is AOT will show calcifications. So usually it will not be just radiolucency, it will be mixed radiolucent radiopaque lesion. Everything else is typical. Anterior maxilla associated with the impacted tooth, everything is same. And AOT is one odontogenic tumor where it will show duct-like structures. Suppose this is a duct. Okay, these are the ductal epithelial cells. If I will draw this is a ductal epithelial cell, and the ductal epithelial cell will have a nucleus, polarized nucleus, that is away from the lumen. Okay, it will have a polarized nucleus away from the lumen, and immediately inside it will have one eosinophilic material here that is called as hyaline ring. And within this inside hyaline ring, it will have again some material here. One material inside here, that is eosinophilic material. So typically a duct-like structure or a rosette with eosinophilic material inside it is characteristic of air. One question came from dental pulp stone. Pulp stones. What exactly is the question? If you can elaborate and let me know, I'll be able to discuss. What exactly is the question? Otherwise, you can post it. You can just give it this here. I'll solve it and let you know whatever is it. Okay. So this is the second question that typically it's again this we have discussed. Again, this image also is there in the notes. This is the image you can see here. These are all the duct-like structures typically, and these duct-like structures, this is what I call it a hyaline ring. This is a hyaline ring, and inside this hyaline ring you will see this eosinophilic material, pink material within it. So this particular structure is the duct-like structure. Okay, so this is a typical diagram of AOT that you are supposed to remember. Okay, let us move to the next question here. A 26-year-old female presented with desquamative gingivitis. What is the differential diagnosis? If you see exactly, typically again we have discussed this 100 times that desquamative gingivitis is a clinical condition. It is not a diagnosis. It's a clinical condition. Patient comes to you with this image, with this picture. This is desquamative gingivitis. So there is shiny gingiva, smooth gingiva, inflamed gingiva. So immediately you will code this patient as desquamative gingivitis. So whenever there is desquamative gingivitis, what you need to do? What is the next step? I will do a biopsy. If I do a biopsy and then I will confirm what exactly is this based on histopathology. Most of the times, remember, the most common cause of desquamative gingivitis is benign mucous membrane pemphigoid. Benign mucous membrane pemphigoid, BMMP, which is also known as cicatricial pemphigoid. Please remember this. This is a very, very important question. Cicatricial pemphigoid or benign mucous membrane pemphigoid is the most common cause of desquamative gingivitis. Okay, so there are other causes like erosive lichen planus is there. Sometimes pemphigus vulgaris can cause. So looking at the options here, the lichen planus is there, cicatricial pemphigoid is there, erythroplakia is there, bullous pemphigoid. See, I'll rule out bullous pemphigoid. Why I'll rule out bullous pemphigoid? Because this has got no oral manifestations. First of all, erythroplakia will be not like smooth, shiny like this. It will be a red patch. There's a red patch. Lichen planus, yes. I told you there are sometimes lichen planus, erosive lichen planus, atrophic lichen planus can present as desquamative gingivitis. It can, but when the two options are there and one option is the most common one, you have to choose that option. Always remember, most common thing should be the best option. So here, okay, let me solve this, Raftan. Once I'll complete this, I'll see your question. Okay, let us move on to the next question here. A 3-year-old child presented with swelling in anterior maxillary gingiva, which is increasing slowly and is firm in consistency. What is the probable diagnosis? See here, basically one point that is missing actually. Presented with swelling in anterior maxilla since birth. Actually, it is there in the question, but not mentioned here. Since birth. See, since birth, the name is there. That means congenital. And the child is having swelling in anterior maxilla. which is slowly increasing. Remember, it is slowly increasing, not rapidly. And firm in consistency. How I will rule out mucocele? Yes, mucocele can't usually is not congenital, and mucocele is not firm, it is soft. Fibroma is usually not congenital. Okay, and fibroma is not, anterior maxilla is not most common site. Pyogenic granuloma, of course, is not congenital. It occurs due to inflammation, due to trauma, that too associated with the hormones. There are certain factors for pyogenic granuloma. So obviously the correct answer would be here congenital. Epules, as the name itself is telling, congenital. Since birth itself, the child has the epulis. Epulis is a small growth. It is firm in consistency. Okay, it can be sessile or pedunculated. Usually typical for anterior maxilla. Usually typical for anterior maxilla. That is congenital epulis. Okay, let us move to the next question here. Fourth question, neurofibroma. No, neurofibroma can't be an option here. See, if an option in the neurofibroma is there, I will rule out neurofibroma clearly. Why will I rule out? First of all, neurofibroma is not congenital. Second point, neurofibroma usually does not occur in anterior maxilla, maxillary gingiva. Okay, so I will rule out. If neurofibroma is there, then also I'll rule out. Instead of fibroma, if neurofibroma is there, also I'll rule out. See, always again the same thing. Most common, congenital epulis occurs in the anterior. This picture we have discussed sharply in the benign malignant tumor chapter. We have seen this thoroughly, that congenital epulis means swelling in the anterior maxilla. There will be basically it is congenital since birth. Okay, let us move to the next question here. A 12-year-old child presented with bifid ribs, palmar pitting, calcification of falx cerebri, and multiple radiolucent lesions within the jaws. The probable diagnosis. Again, this has been discussed multiple times. There is one of the important syndrome which is associated with multiple OKCs. That is the nevoid basal cell carcinoma or Gorlin-Gott syndrome, where this Gorlin-Gott syndrome has got some major criteria, some minor criteria. Already we have discussed this. The major criteria is nothing but it has got basal cell carcinomas, it has got multiple OKCs, it has got palmar pits, it has falx cerebri calcification, it has bifid ribs. All these are major criteria. The same points have been asked here. So this is what is your nevoid basal cell carcinoma syndrome. Again, a simple single liner MCQ which has been discussed. Okay, the minor criteria are there for the this one, nevoid basal cell carcinoma syndrome. Usually minor criteria are not given much emphasis. A separate MCQ is not asked on minor criteria. Just we need to know the for criteria for diagnose nevoid basal cell carcinoma, at least you should have 2 major or 1 major, 2 minor. Either 2 major should be there or 1 major plus 2 minor. This is the actually the rule what they say, but doesn't matter. This question doesn't come like this. Major, minor, they won't ask you like this. Just you need to know the clinical features for nevoid basal cell carcinoma syndrome. Okay, a 14-year-old child presented with hyperelasticity of skin, hyperextensibility of joints, frequent bruising, delayed wound healing. Again, this we have discussed. There is a syndrome called as Rubberman syndrome or Ehlers-Danlos syndrome. What happens in this patient? Typically in this Rubberman syndrome patients or Ehlers-Danlos syndrome patients, they have the ability to stretch their skin. This image you can see here, they have so ability to stretch their skin to that extent. They can move their hypermobility of the joints. EMJ, or most important for us to discuss is EMJ. There will be hypermobility. Okay, so these are very important points which are nothing but about the Ehlers-Danlos syndrome or Rubberman syndrome. That is why it's called as a Rubberman syndrome. Okay, let us move to the next question here. The next question is, as a patient presents with a fine sparse hair, deformed nails, anodontia, and decreased wedding, the probable diagnosis. This is the first topic we have discussed in skin diseases, that is ectodermal dysplasia. We have discussed that ectodermal dysplasia is a condition in which all ectodermal structures, skin, hair, nails, teeth, all are affected. So here the patient will have a very sparse hair, very few hair, very fine hair. Teeth will be very few, teeth will be there. There is anodontia will be seen. And if you see, they have decreased sweating. They have decreased sweating. They have got triple. They have got as hypohidrosis, that is decreased sweating. Hypotrichosis, that is less number of hair is seen, and hypodontia. So this is a triad that you see in case of ectodermal dysplasia. Ectodermal dysplasia. Okay, so this is again a typical image where I want to show you the less number of teeth, and whichever teeth are there, they are cone shaped or conical shaped teeth. Okay, right, great. So let us move on to the next question here. Which of the following is not a finding of Pierre-Robin syndrome? See, we have discussed this in the bone. Pierre-Robin syndrome. Actually, it's not syndrome, it's a sequence. First, the patient will have micrognathia. Because of micrognathia, the tongue doesn't come down. The tongue will have glossoptosis. That is falling back of tongue. And as the tongue is there in the upper position, the palate doesn't fuse. So cleft palate. So 1, 2, 3 options A, B, C are correct. Upper airway obstruction takes place. Yes, but it is not a definite finding. Triad is only these three. We have discussed this triad of Pierre-Robin syndrome. Micrognathia or retrognathia of the mandible. Glossoptosis. What is glossoptosis? Falling back of the tongue. And cleft palate. Upper airway obstruction can occur, but it is a secondary effect. Remember, secondary effect of the glossoptosis. Okay, so that is the important point you have to remember about the Pierre-Robin syndrome. So if you see here, typical patients of Pierre-Robin syndrome, where the primary enamel, remember the main primary enamel is hypoplastic mandible. As the mandible is hypoplastic, the patients will have glossoptosis, that is falling back of the tongue, and there will be cleft palatal enamel. Okay, that's an important one you have to remember. These three are the triad. Okay, let us move to the next question. It's again simple. Which of the following syndrome is associated with recurrent oral ulcers? Again, in the chapter of allergic and immunological diseases, we have discussed that Behcet syndrome. Okay, Behcet syndrome is one important syndrome which is associated with a recurrent oral ulceration. Recurrent oral ulceration. So if you see this Behcet syndrome is basically has got one the required criteria. Definitely 100% of the patients should have oral ulcers. Remember, to call a patient as Behcet syndrome, 100% of the patients should have oral ulcers. There are other criteria also, but the most important one for us is the recurrent oral ulceration. Okay, that's about the Behcet syndrome. That's a 9th question. Other cleidocranial dysostosis, nothing to do with the oral ulcers. Gardner syndrome, nothing to do with the oral ulcers. Beckwith-Wiedemann syndrome has got nothing to do with oral ulcers. Which of the following are clinical features of nasopalatine cyst? Anterior palatal swelling, bluish discoloration of the incisive papilla, discoloration of the maxillary incisors, salty taste in the mouth. See, typically again we have discussed this when I have discussed the cysts. First of all, anterior palatal swelling, yes, it's right. Bluish discoloration of incisive papilla, yes, there is swelling and there is discoloration. Discoloration of maxillary incisors, why it should take place? It is not required. See, if it is a tooth is a non-vital, then only there will be discoloration. In nasopalatine cyst, is the tooth vital or non-vital? It is vital. So you will not see the discoloration of maxillary incisors. And you will see salty taste in the mouth. Obviously salty taste because nasopalatine. So nasal secretions will be there in the oral cavity. Because of that, there will be salty taste. So correct answer should be 1, 2 and 4. But now here if you see 1, 2, 4 is not there at all in the options. 1, 2 are there, 1, 2, 3 is there, 2, 3, 4 are there, 1, 3 is there. See, I will rule out 3. 3 should not be there. So obviously this 3 is not there, 3 is not there, 3 is not there. So remaining option is only this one. 1, 2, 1. Okay. So 3 I will rule out. Discoloration of maxillary incisors not seen in nasopalatine cyst. Sometimes you need to think. It's a common sense question. When a tooth will get discolored? Whenever a tooth is non-vital. How a tooth will be non-vital? Whenever there is a caries or a trauma. Here, nasopalatine cyst has got nothing to do with the tooth itself. See, nasopalatine, I'll show you an image. Nasopalatine is occurring in this region. You can see here. Has it got any relation with the tooth? No relation. That is why you have to think sometimes. The examiner wants to just confuse you. Just wants to confuse you. Okay, next question. A female, 45-year-old female presented with 2 cm palatal ulcer with dark necrotic base. This is suggestive of. See, actually this question again is misleading. Why? I'll tell you. First of all, a female with 2 cm palatal swelling with necrotic base. See, this is a very incomplete question they have asked. Very incomplete question they have asked. 2 cm palate. If they'll show you this image, necrotic ulcer on the palate, they should give you some history actually. Like a female patient or a male patient who is a smoker, the correct answer will be necrotizing xylometaplasia. Why I am choosing necrotizing? You can ask you why you were not choosing squamous cell carcinoma, sir. Because squamous cell carcinoma, if you see the ulcer, will be usually not irregular ulcer. It won't be like this typically 2 cm small regular margin, something like not like that. It will be irregular ulcer. It will have a you can say ragged borders, ill-defined margins. Mucoepidermal carcinoma is also like that, only same. Mucormycosis is destructive. It is not localized, it is destructive. So if you look at this, typically this is due to the heat. Remember, typically it occurs because of heat, and the cause for heat is smoking. Because of smoking, because heat is produced and that heat causes the ulcers on the palate. This is typically a necrotizing xylometaplasia. Okay. Moving on to the last question here. Scarcity of inflammatory cell infiltrate in vesicular fluid in vesiculoablations lesions are seen in. I'm sorry, I think I have not discussed this question. Only this is one which I have not discussed. Out of these 12, 11 we are typically are there in notes. This is the one which is actually, if you apply indirectly, I have told, but not directly. All the other 11 directly we have discussed. This is the one which we have not discussed directly. If you can see here, scarcity, that means inflammatory cells are less here. Among the 3, 1 doesn't have inflammatory cells, much. If you can see this, lichen planus typically have dense band of lymphocytes, and pemphigoid typically will have eosinophils and neutrophils. It is pemphigus vulgaris which has got nothing to do with the inflammatory cells. So that is the reason that pemphigus vulgaris will have the scarcity of the inflammatory cells. So this we know. In the notes we have written this also, that pemphigoid will have eosinophils, that we are not written neutrophils. So nothing to do with the pemphigus vulgaris with the inflammatory cells. Okay, so that is what I just wanted to discuss with you people. There's questions. There is, which of the following is Pulp testing, please ask endo. Pulp testing is not related to the oral pathology. Please ask endo faculty, they'll explain you. Okay, great. Okay, so I hope this session would have helped you. So we'll definitely have many more such sessions, and we'll discuss. So that's what I'm telling you. If you read the notes, always I have been emphasizing, read the notes. It's not just only my subject of oral pathology. Any faculty, read the notes. Be careful to the in understanding the concepts. If you understand the concepts, nothing is difficult. Nothing is difficult. I'm telling you. Try to understand the concepts. Try to remember or memorize those things. Uh, yes, I'll just discuss. Last question. See, scarcity of the inflammatory cell infiltrate in vesicular fluid in vesicular obliterations are. The question they are asking is, they are given 4 options, and they're asking in one option inflammatory cells are less. Okay, so if you see here lichen planus, I will rule out that inflammatory cells will be more. Why? Because dense lymphocytes are seen in lichen planus. In pemphigoid, let it be cicatricial or let it be bullous, eosinophils and neutrophils are seen. So by ruling out like this, we can see that it could be pemphigus vulgaris. The correct answer should be pemphigus vulgaris. Okay. Pulp stone, yes. I'll come back to the question. See, what the which of the following is not a type of dental pulp stone? True, false, embedded, attack. See, there are basically 2 types of classification are there. I'll tell you the classification. So one is like dental pulp stone can be free pulp stone, attached pulp stone, embedded pulp stone. Another way of classification is true or false. True or false. If you can see here, the question is, they have given free, they have given the embedded, they have given true, they have given false. All the types are there. But among this, I recommend you to go with the false type. It is not a type of dental pulp. Okay. Rather, you will call it as denticle, false denticle. False denticle. Because it will not have a dentine-like structure. So, free, attached, embedded, and true are all correct. False is the one with better option you can choose. Better option you can choose. Any other doubts? Any other topic which I have not covered, or any MCQ question we have not discussed here? Please let me know any options I need to correct. I hope this session would have helped you people. So all the best. Keep studying. Thank you so much.